Moving on to our next presentation. Ladies and gentlemen, resistant hypertension remains a major clinical gap in our daily practice, and despite multiple drugs, still patients remain uncontrolled. With the recent approval of the drug aprocitentan, a dual endothelin receptor antagonist is being considered a game changer in the management of resistant hypertension. To talk about it, I would like to invite Professor Dr. Feroz Memon. He is a distinguished cardiologist, professor of cardiology and vice chancellor, Indus Medical College, University of Modern Sciences, Tando Muhammad Khan. Professor Dr. Feroz Memon.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much. I'm grateful to Professor Aftab Mohsin, Dr. Somia, and my very dear friend, Professor Javed Akram, who always remembers me and honors me to call in here. Bismillahirrahmanirrahim. I've not much to claim. We have just an educative slides and presentation, and what we talk of is a silent killer, which is hypertension, and resistant hypertension is one of the forefathers of hypertension. This hypertension causes 7.5 million deaths worldwide. It's about 13% of global total deaths, and 45% of them are due to heart disease. Now, this was a global survey in 2000 when they showed that around 1 billion people were hypertensive, and 2025 there will be 156 billion people hypertensive. In fact, we are more than that, about 2 billion people in the world. Pakistan is no less behind. Only 37% over 25 years were ever had the blood checked in the year 2005. हम blood पे check नहीं कराते because there are no symptoms, there are no signs. We think हम बिल्कुल ठीक हैं. Women are generally more likely than men to have their blood pressure checked, and among hypertensives, greater than 85% rural areas and greater than 45% in urban areas are unaware of their disease, where they don't check it, they don't go to see doctor. When I was asking my final MBBS class, about 30% students have only checked their blood pressure, baki 70% kabhi check कराए नहीं, कि sir we are all right, so why should we do it? If you get such a low number of awareness, obviously it is ineffective, not treatment. Basically, hypertension sustained elevation of resting systolic blood pressure greater than 140, which is now 130 in many places, and diastolic greater than 90. So overall, adjusted prevalence of hypertension in Pakistan was given by Professor Basit and his group, which was 46% self-reported hypertension and 21% of newly diagnosed. This really brought an uproar in our society. Ke itni zyada log hain kya? Now, this was a small program we conduct with the help of World Hypertension Federation. Every year we trace people in the society, in the community for blood pressure. These plans, programs were accepted by European Journal, Heart Journal, and averagely we had a blood pressure prevalence of 46 to 52% of the people had it. This was in the society. So the problem is that although over 10 million lives are lost each year due to high blood pressure, only 50% of people affected are aware that they have got this problem. So what they say, what blood pressure hai, hame kuch nahi hota. Why should I take a medicine now to have a symptom rather than just get it? But then don't realize that what you get is heart attack, renal failure, blood vessel damage, neurological disorders, retinopathy, and obviously headaches, and these are all irreversible phenomena. If you look at things, फालिश तो फलाने बंदे को था, वो दवाई खाता था, फिर भी उसको हो गया 70 साल की उम्र में. It's all right if it had 70 years, but not at 30 years. These three gentlemen, Prime Minister Churchill, President Roosevelt, and Prime Minister Stalin, all were the cause of hypertensive strokes. And there was a very interesting finding that one of the scientists and physicians said a very cruel term that the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. But a Ghair Parliament love use kiya tha in science. And then Dudley White is one of the famous cardiologists from UK. We all used to read the books as well. And he says that hypertension may be an important compensatory mechanism which should not be tampered with. कुछ नहीं करो उसको, even were it certain that we can control it. छोड़ दें उसको uncontrolled रहने दें. And then this is where the bomb blasted. President Franklin Roosevelt died of hemorrhagic stroke on April 12, 45. his blood pressure was estimated astounding 350 by 195, and no one had a clue about its relevance. किसी को पता नहीं था, उन्होंने कहा जी blood pressure तो control करना ही नहीं है. So his cardiologist laminated in the Annals of Internal Medicine. I've often wondered what turn the subsequent course of history might have taken to if modern methods for control of hypertension had been available. And we had this in second lecture. We were talking of hypertensive strokes and hemorrhagic flows and how could we save them. And they've saved with a wonderful program. They've saved a lot of lives. Now, clinical trials definitely show that treatments associated with control of blood pressure have 30 to 40% risk reduction in stroke, 25% MIs, and 50% in heart failure. But after that, are we in control of hypertension? No, sir. We have got so many patients here, and at present, we have got a very small number of patients who are known their blood pressure and who are still not controlled. Although, if we see that if we reduce 2 millimeters of systolic blood pressure, we can reduce a risk of 7% reduction in stroke and 10% risk in stroke mortality and disease mortality. So, itna benefit hai, to hona chahiye na. But what happens in Pakistan? We have got Pakistan Hypertension League, we have got different societies, even in PSIM, you are having programs on control, awareness and diagnosis of blood pressure. What happens is that in Pakistan, 34% people are diagnosed, out of those 25% are treated, 44% are treated, and only 11% of them are controlled and they are good. Otherwise, even I have seen our very good doctors come to us after 1 year and they say, "Hum theek the, tumne dawai chhod di." Now this is what they will be told. As such hypertension, now we say that normal is 120 by 80, pre-hypertension is less than 140 and less than 90, high blood pressure is stage 1, 140 to 160, 90 to 99, and stage 2 is 160, but we call it hypertensive crisis if you have blood pressure more than 180. But when it is controlled, despite the use of 3 medicines, including a diuretic, then this is known as resistant hypertension. Now, by definition, failure to achieve the goal, blood pressure in patients who are adhering to full doses of appropriate 3-drug regime that includes diuretic and blood pressure is not controlled, or 4 drugs in a row not controlled, this is not synonymous with uncontrolled hypertension or diffuse hypertension like secondary hypertension or some other cause of hypertension which we can treat it. Resistant tab hai jab we are treating a primary hypertension with 3 or more than 3 drugs that includes diuretic. And if you look at the ESC treatment, recommendation is that initial phase we give 1 pill, either S inhibitor, ARB or a CCB. Step 2 we give a combination of AS inhibitor, CCB, diuretic. Step 3 is when we definitely add spironolactone to this treatment, and even if it is not controlled and it's confirmed that patient is taking the medicine, it is resistant hypertension. So the blood pressure remains above 130 by 80. Despite concurrent use of at least 3 antihypertensive agents, it becomes resistant hypertension. But for management, we have to confirm the treatment resistance, aggressive lifestyle changes. As Abhi Jafri sahab ne kaha कि कितना दौड़ना, कितने स्टेप चलने, 6,000 करे थे, हम तो 10,000 की बात करते हैं. Treatment of secondary causes if you have, and then a proper drug therapy which patient must take, not that he chooses and decide which drug you can. I always tell them, this is not a buffet dinner or lunch where you can choose the items you want. If you've got 3 drugs, you have to take the 3 drugs. You cannot decide कि एक मैं उसमें avoid कर दूँ. दूसरी चीज़ जो most important is confirmed office and home blood pressure. The increased tendency now that you must check your blood pressure at home, because going to office they think doctors are devil, and devilish character raises the blood pressure. White coat hypertension और भी खराब होता है. So we can do it at home monitoring or a 24-hour ambulatory blood pressure monitoring. And then we also must realize that we must eliminate interfering substances like painkiller, pain, anxiety, and things like that. Now overall, after this talk of hypertension and everything, the resistant hypertension have got 21% people with hypertension who have got resistant hypertension. A real great number, a big number, and causes, the major cause is, as you can see, the primary cause is the suboptimal medical regime. हम अभी भी कहते हैं 3 दवाइयाँ ले रहा है कि वो 3 दवाइयाँ proper dose में ले रहा है या homeopathic dose में ले रहा है. Then non-adherence is a very common thing. Office resistance, कोई खतरनाक boss आ गया. Psychological causes, बीवी लड़ा का है. Secondary hypertension and interfering substances. With due apologies to a panel of experts, with female are there, so I do apologize for the comments. Pathophysiology is inappropriate high sympathetic outflow, high aldosterone plasma renin engine activity, abnormal renal salt and water handling, vascular reactivity, and variable patterns of cardiac output which will lead to this problem. Now, hemodynamics, this RAS involvement with sympathetic nervous system, sodium retention again itself, and then again all of these factors work together to lead to excess volume, which reaches to dietary sodium, reduced GFR, aldosterone excess, and it could be vascular resistance with RAS activation, SNS activation, and arterial remodeling, and these things would be the cause of hemodynamic causes. Now, it's very important that we identify the people who are at high risk of having reversible causes of hypertension, and patients who become persistently high blood pressure levels may benefit from special diagnostic therapeutic consideration. But now, because we have got 90% people having primary hypertension, so we do not go into investigation of everybody, but there will be a specific population where we must put our time, put our effort and find out, so that otherwise you'll increase the risk of cardiovascular disease and renal disease, and different management strategies could be used. Now, risk factors are such as for hypertension are the same, but the strongest predictor are obesity, diabetes, and high blood pressure. So even a diabetologist was talking of Mansfield, and we agree on the same risk factors, whether it's diabetes, it's hypertension, ischemic heart disease. The symptoms that come on are with dizziness, headache, vision problems, nausea, trouble breathing, and complications. I have said it's coronary artery disease, heart failure, stroke, pulmonary artery disease, and all-cause mortality. Now, what we have got, apart from major drugs, there's a new drug coming, which is the first endothelin receptor antagonist for the treatment of hypertension. It's a novel first-in-class of endothelin receptor antagonist indicated as an adjunct therapy for resistant hypertension. It is not the therapy, but it's an adjunct therapy, the treatment. Now, aprocitentan blocks ET receptors. They're preventing ET1-induced vasoconstriction and vascular muscle relaxation, which leads to vasodilation. So if we can avoid vasoconstriction by preventing ET1, and then we prevent vasodilation, this will reduce blood pressure. Now, guideline recommendation recommend aprocitentan for difficult to control resistant high blood pressure. That's where it is used. It's recommended by American Heart Association and European Society of Cardiology, and its basic short half-life, 41 hours half-life, and excreted mainly through urine and through feces. Clinical evidence of aprocitentan is that it's a dual endothelin blocker and showed a BP reduction in 14 days with broader cardiovascular protection and sustained efficacy with fewer withdrawal symptoms. Now, there was a trial, precision trial, where we give aprocitentan 12.5 milligram. To other group, it was given 25 milligram, and then placebo. Part 2, we reversed them. And then what we saw is at 4 weeks, 15.3 millimeter mercury blood was reduced, with 24-hour systolic blood of 4.2 millimeters and diastolic 4.3 millimeters. And there was a significant 28% reduction in UPCR ratio, reduced organ damage in chronic kidney disease, and sustained antiproteinic effects also. Now, efficacy was that with beta blockers it reduced 14.9, but the group which has no beta blocker, it was 16.5. So it's a very effective drug with 3 classes. Adverse reaction, as with all such drugs, is anemia and edema, and drug interaction is that we will be careful with UTGT inducers like rifampicin and phenobarbital, and its use in specific problem pregnancy is contraindicated. Lactation, there's no data. For hepatic impairment, no adjustment needs. For geriatric, it's safe and effective. Pediatrics, not recommended. Renal impairment, no dose adjustment seen. So resistant hypertension, for administration, you use the drug, 1 tablet, 12.5 milligram once daily, along with other therapy, and this has been approved by US FDA, European Union, and MHRA UK. And then, in conclusion, a novel first-in-class endothelin receptor antagonist, a strong dual endothelin ET pathway blocker as an adjunct therapy for resistant hypertension, significant blood pressure reduction within 14 days, recommended doses 12.5 milligram once daily. So just one of the narration I want to give, कि हुजूर सल्लल्लाहु अलैहि वसल्लम ने फरमाया है कि there are two blessings which many people lose, उसका फ़ायदा नहीं उठाते, and they are health, उनकी अपनी सेहत, other one is free time for doing good, for good doing services like the people here are doing for hemorrhagic stroke and these things. So we must see that we must take care of our health and make use of a free time. Jazakallah. Thank you so much.
Thank you very much, sir, for enlightening us with resistant hypertension.